Assalamu alaikum. Now I would like to talk about bias. It's a very interesting topic in bias stat, but it's hard actually. In selection bias, what is selection bias? In selection bias, there is non-random sampling or treatment allocation of subjects, such as study population is not representative of the target population. In here, study population is not the representative of the target population. In selection bias, what are the components or what are the examples? In selection bias, one is Bergson bias, one is attrition bias. What is Bergson bias? Bergson bias is like I'm selecting uh, I'm selecting the population. I'm selecting the sampling from a particular area. Like case and controls are selected from hospitals. That means bedside bias is Bergson bias, are less healthy and have different exposure. While selecting the sampling, I should be randomized, not picking that, because everyone coming to the hospital, he or she might have some disease. He's not here to roam around. So if I am picking that particular patient from that particular area, then my bias will then I will be biased actually. So it is selection bias. What is attrition bias? Attrition bias is participants fails to follow up. Like you are selecting 10 healthy people and 10 uh, that you are selecting 20 people. From 20 people there is 10 healthy and 10 unhealthy, and from the from 1 year later, 1 year later, you are getting you are failed to follow up the 5 healthy patient and 1 unhealthy patient, and if the result is published, then you will get bias because the ratio is not equal and the patient fails to follow up, so prognosis or the completing study would be different. Patient fails to follow up to a different prognosis than those who complete the study. What is recall bias? Recall bias is patients with the disease recall the exposure after learning the similar cases. Patient actually know about the disease, so after patient with disease recall exposure after learning the similar cases. Uh, Suppose if somebody has chicken pox and they get affected in the chicken pox again, or if somebody has hepatitis, viral hepatitis, and he get viral hepatitis again, so he knows the he actually knew the outcome, he know the uh, possibilities, what will happen there, then what will happen now. Somebody, it is more common in nowadays that patient having enteric fever, again they are getting enteric fever, and after getting enteric fever, they actually know the pain and the problems happens in enteric fever, so they get biased. So awareness of the disorder alters recall by the subjects common in retrospective study. Decrease time exposure from to follow up, use medical records and resources. What is lead time bias and what is length time bias? In interpreting results, there is lead time bias and there is length time bias. In lead time bias, like a patient has breast cancer, and we know that mammography and and other tools actually diagnosed early diagnosed early, and by doing mammography and by doing early the detection, we can increase the survival. But the disease the course will not gonna change. Like a person having a lung cancer, whenever you are going to diagnose, he has limited survival rate, like 1 year, 2 year. He will, we are seeing that we are increasing the survival, but actually the disease course would be the similar. Early detection, early detection will not gonna increase the survival. So in here there is measure back end survival, adjust survival according to the severity of the disease at the time of the diagnosis. And in length time bias, like in length time bias, the slowly progressive disease, we can easily detect a slowly progressive disease. On the other hand, it is hard to diagnose a it is hard to diagnose but it is hard to detect a rapidly progressive cancer. So screening test detects disease with a long latency period, while those with the shorter latency period become symptomatic earlier. In randomized control trial, a RCT, assigning subjects to the screening program or to no screening. What is observer expectancy bias? In observer expectancy bias and in procedure bias, we can overcome those observer expectancy bias and procedural bias by blinding and use a placebo to reduce the influence of the participants and researchers on procedures and interpretation of the outcome, as neither are aware of the group assignment. In procedure bias, patients in treatment group spend more time in a highly specialized hospital unit. In observer expectancy bias, an observer expecting the treatment group shows a good recovery. This is observer expectancy bias. If observer knows that this is the drug and this is placebo, so he will focus on those patients who are having those drugs, and this is observer expectancy bias. Uh, in in measurement bias, there is Hawthorne effect, that if somebody is observing your work, then your working would be better. Your working would be better. So use placebo group in that particular case. In recall bias decrease time from exposure to follow-up. Use medical records as resources. And in confounding bias, what have wha- in confounding bias, we are actually dealing that drinking coffee causes lung cancer. This is crude analysis, but in stratified analysis, that we are looking that those who are drinking coffee, who are have who actually having smokes as well, and they are getting lung cancer. Apart from those who are not doing smoking, they actually get less cancer. So in here, matching patients with similar characteristics in both treatment and control group, matching is one of the thing we can overcome this confounding bias, overcome this confound. And effect modification, in effect modification, OCP, crude analysis, OCPUs causes DVT. And stratified analysis will done by OCPUs, smoker causing DVT, OCPUs, and non-smoker usually causing less DVT. So stratified analysis, after testing the interaction between OCP and smoking, analyzes the risk among the smokers and the non-smoker, analyze between the smokers and non-smoker. This is effect modification. This is effect modification, and that is all about the bias. Hope you enjoy.